Hi, I'm Dr. Clark Brinton, and this is Dr. Seth Huish. We're with Roots Dental Implant Center. We just wanted to make an educational video around what dental implants are and different applications.
We're thrilled to introduce what this could mean for you, how it can apply. Dental implants have been around for some time, and there's certain instances where it makes a lot of sense to have one placed in your mouth.
Yeah, I mean, really, they're pretty much any application to replace missing teeth. So we, in our practice, focus a lot on full mouth replacement with fixed bridges, sometimes called all-on-4. But we're going to start in the beginning with if someone is just missing a single tooth, what are the options there? We have a little model we brought with us today. So if there's a missing tooth, we'll place a titanium dental implant as sterile, medical grade titanium. Essentially looks like a little screw. And we call it a root replacement. It goes in and in the location where the natural tooth root was. We place this fixture in there. It takes about 3 months for that to heal, and then we'll place an attachment, which we call an abutment, and a crown on that. And that acts a lot like a single tooth. You can floss around it, brush around it like you would a natural tooth. And if it's maintained well, that can last a lifetime.
And historically, the big advantage to an implant versus a bridge or a partial is that in a bridge setting, you're drilling on teeth that may not need to be worked on otherwise, which put it at a higher risk of having issues, needing root canals, loosening up, things like that. Or partials that snap in and out can be bulky, can cause other issues, gum disease, where these are really, really clean, really straightforward, and definitely the best option. People who get single implants done, there's different ways to restore them. And so it's worth asking when you are getting it done from a dental office, kind of what their methodology is a little bit. Make sure they have a great lab they work with. There's different restorative options.
Yeah, that's a great point. I think technology, you also want somebody that doesn't do an implant like once a month. You want someone that it's a regular part of their practice. And if you walk in the office and they don't use 3D imaging, digital 3D imaging, in 2024 it's probably worth looking around and finding someone else that's a little more versed. Most offices are using 3D intraoral scanning at this point to have the final fabricated, which we find brings a lot more accuracy. It's also a lot better patient experience.
Oh, 100%.
Not having the goopy impressions. Those suck.
They're the worst. Yeah, and now you can come in, it's such a smooth process, it's really comfortable. Patients love it, where you come in and we wave a little wand around that stitches all the images together, which makes it a really pretty smooth process. And those, who've had the big tray, metal, plastic tray in the mouth, gets in their hair and on their face, versus what we can do now. It's more accurate, there's no warping, it's way more comfortable, and we get great results. My favorite is when we put the final crown in, hand you a mirror, and you can see it just blends right in. You treat it like another tooth, you floss it, you brush it, it just behaves much like a tooth that you had before.
Well, and like Seth said, a lot of the patients don't really care to know how the sausage is made, so to speak. They just want a nice final result that's going to last and work well for them. But we have kind of been in the weeds on that. Started a digital dental lab in 2018, and we've been involved in both sides of the process since then. And that's been super cool to see the advancement in a relatively short amount of time in the last 6 years. We had one of the first 3D printers in dental, and now that's a huge part of the process, the digital imaging and scanning, and also the CAD/CAM applications on the back end have just made it come from a kind of an artisan lost wax technique is where we started with casting and all that. And now being a digital process, it's just a lot less trial and error, so much more accurate. And in our practices, the cost has actually come down because of the streamlined digital workflows. We're able to pass that cost on.
It's come a long ways. I mean, to toot your horn a little bit, you're over there working at the OHSU as an adjunct faculty, helping with the digital workflow over there, so they can also, when we were back in school, we were casting gold and broken arm technique and this whole thing. Where now we're actually been asked to come back in, show them how to use the digital workflow, which has been a big deal. How to design, how to print, how to do try-ins. which is it's a whole new digital world, which when this technology is applied in the right way, you get great results. It looks really natural. They feel great. They look great. Aesthetically, it's just really important to get it right.
Yeah, and it is crazy, right? We're just over a decade out of school, and the landscape is completely different. When we graduated, in 2013, how things are done then and how they're done now. It's an exciting time, I think, to be in dentistry for that reason, is we do have a lot of great tech that ultimately, for the patient, just becomes less expensive, less time, less appointments in the office, less time at those appointments, and then just less uncomfortable, really.
Sure.
With all the try-ins and the goopy impressions and all that stuff that we've now ditched.
What cell phone did you have when we were in school?
Yeah, I mean, that was pre-iPhone, right?
I think I had a slider. It was awesome. It got pretty good at the old keypad.
Yeah, well, iPhone had just come out, but we couldn't afford it.
Back then, that's right. Yeah, it's very different. But you look at the tech then, you look at the tech now, and same thing trend, with the technology in dental. It's just the same thing. It's just gotten better and better. And so now you look at what you can do on your phone, you look at what you can do in dentistry. And so I think that's important as a consumer, as someone who's going to get this done, that you're not stuck in the era of, a slider or someone. You want someone who's current, who has the best technology, because you can get a better result. And it really, you can see the difference if you have some of that old technology. It really just stands out.
Yeah, that is interesting, right? I think if I were to go get an implant done, I would want to find somebody that was experienced. You want to be the guinea pig, so to speak. But you also don't want the guy that's done everything the same way for 35 years, because we see that too, and that's... So I think there's definitely a sweet spot there, right?
There's a sweet spot.
Someone who's up on the technology, knows the process, detail-oriented.
That's right.
Patient-focused, obviously, but has that blend of experience and technology.
Yeah, it makes a big difference. I agree. So the next thing we should talk about is really just the kind of thing we do a lot of, which is the full mouth restoration. And, not that long ago, some of the things we were doing were just dentures, right? Full mouth restoration was a denture. And we know, it's not a surprise that they're not a great solution. That was cutting edge technology with George Washington.
Yeah. Well, yeah. We've upgraded a little, but no big changes since the 1950s, right?
Sure, right.
It's a piece of plastic that you wear in your mouth, and a huge part of our patient base, our clientele, are denture wearers.
Right.
Which tells us that we hear it every day. They're just not happy with them, and I can understand it. It's like losing your leg and getting a prosthetic that isn't attached, and you can't function well, and that's kind of what we see. We see, especially on the roof of the mouth, right? Having that plastic flange covering the roof of the mouth.
Oh yeah.
Affects speech. It affects taste. And then I think what I underappreciated a decade ago that I'm really keyed into now is the psychological impact.
Oh, for sure.
It's just like...
Well, people don't want to go out. They don't want to go out to dinners, be around family. They want to sneeze and have their teeth in their mouth.
Yeah.
They don't have to pull things out and clean it at the table. Yeah, it makes a big difference.
Yeah, and then, everybody's living longer too. I think there's that psychological thing of, if your teeth come out and go in a jar before you go to bed, you're old. People don't want to be old.
No, of course. We're living longer, we're healthier, we're more health conscious. It makes a big difference. I completely agree.
Yeah, and to the health aspect, I think that's another thing that I appreciate more now is, and it's common sense, but you just don't think about it if you're not in that situation.
Well, of course.
Of when you're wearing a denture, you can't eat healthy food, right? Everything that's healthy is crunchy. Carrots, celery, vegetables, even a good steak. There's also research behind that too, right? About
sure.
The obesity. If things are too soft, you eat them too quickly. You eat too much, so it short circuits the whole biology that we're based on. To not have something that allows you to crush and grind up your food.
Of course.
Before you swallow it.
Well, we hear people all the time talking about gagging on their food and almost choking, or having had those experiences. They can't get it down. They've researched this, and it's not new research, but we know with the traditional denture, for example, an upper is at best about 30% chewing force, lower at best is about 15%. So you've lost so much functionality. You're stuck with certain limitations of things you can eat. They might look okay until you smile too big, and then they fall down.
Yeah, that was when I was in public health. That was my pitch, right? It was, we'll make you this, but it's all show and no go.
And the best you can do, goop it all up with the glues and things like that, and it's never ideal.
Yeah.
Never ideal. And that's the difference, because now when you know, versus fit 10 and 30%, and now you can get them in a position with implants where you're at 90, 95%. They're as natural as you can get.
Yeah. Yeah, and I mean, and you know, I look at our progression through this process over the last decade is, you know, 10 years ago we were doing a lot of overdentures. Right? And those are
That's right.
an improvement over a normal denture because, you know, for those watching, an overdenture is placing a couple implants that clip on or snap onto the denture so that it's retained in the mouth better.
Well, it replaced the glue, right? So now you don't have to do the glue, which was a big improvement.
That's an improvement, but I think at the end of the day, the problem is it's still a denture. And that's kind of what I bumped up against with my patients is, it's a better denture. It stays put better, but it still has the denture problems. It still has the flanges. It's still a piece of plastic that comes in and out.
Well, there's a lot of maintenance on it. You've probably seen it all. I do all the time. You come in, you have to replace the gaskets. You got to update this and that. Things will chip and break. And there's people are in much more frequently when they have those versus something that's more of a fixed option.
Yeah, I mean, to be fair, everything, you know, natural teeth, fixed implants, everything requires maintenance if they want it to last. Just like a car, you know, you got to bring it in for regular oil changes.
Sure.
But you're right, the overdenture with those little either rubber gaskets or the little nylon inserts, they just wear out.
They just wear out.
And it just becomes like an ongoing saga, right?
Yeah, 5-10 years ago, I was doing a lot of those. I've actually shifted completely, and maybe we talk more about the fixed option now. A lot of people hear them called the all-on-4s, fixed hybrid dentures, a couple different names for it. Some people have coined other terms, but essentially they're the same thing.
Yeah, absolutely. And you know, we've gone back and converted a lot of those overdenture patients to a fixed option.
That's right.
And it's night and day better. You know, like I said, there's no perfect option, but the all-on-4 is as close as you can get to set of natural teeth. I think you said 95% of the way there, and I think that's how our patients see it.
And that they look natural. Well, I had a patient just the other day. She commented to me. She'd been at the cafe. The waitress came by and she said, "I just have to ask you, what's your secret? You have such beautiful teeth." You know, and she smiled to herself and she said, "Well, they're implant teeth, you know." But they do. They just look natural. She can order anything on the menu. She can eat anything she wants. She can go to the farmer's market, get fresh carrots, nuts, you know, you name it. Anything she wants to eat. There's nothing off the table as far as eating options.
Yeah, that's a huge improvement functionally. Back to what I was saying about dentures, though, the psychology component of it.
Oh yeah,
that's what really blows me away is when they go from dentures into the glass at night, or you know, like you said, falling out when they're trying to eat with friends, to having something fixed and secure, then it just feels like their own again.
That's
like
right.
you said, they're implant bridges, but they start to feel like they've got their own teeth again. And just to see the social impact that makes for people,
that's huge.
It's been phenomenal. You know, I can't count the number of patients that you see them back. It's fun, right? You see them back every 4 to 6 months for maintenance and kind of catch up on how life's going.
Family,
you know,
grandkids, traveling. They're focused on life instead of, you know, on the flip side, people coming in for relines, hard relines, soft relines, you know, making new sets of dentures. And the thing is, with implants, the bone stabilizes. And so we see this play out constantly. And with the traditional denture, you see this atrophy, right? And so it doesn't play out very well because you're going to continue to atrophy, where these are stable. And people, you're right, they just come in, they're just, you know, and I hear this 5, 6, 7 years later with the fixed set. People just look at me and they say, "Dr. Huish, you know, this is the best decision I ever made. The best money I ever spent. I just wish I would have done it sooner." They're just super happy with it.
Yeah, that's for sure. And I think for me, it's been fun to see people. You know, we have obviously different patients, different life situations, but you know, sometimes we get those patients that have made some poor decisions or just have gotten into a tough situation, and they're trying to get their life back together. You know, whether it was drug use or neglect or whatever other thing. And you know, I think that's, you know, we're obviously not psychologists and not licensed to do anything that way, but it's fun to be part of that process too, where, you know, they come in and it's kind of a broken person and we help them get that part of their life back together. And sometimes it just gives them momentum, right? They get their teeth fixed, they can get a better job.
Yep.
They, you know, relationship status changes.
Yep.
So that's really fun for me to see too.
Oh, completely. It's a huge difference. And although we don't want to judge people on their teeth, as humans, it's something we can't help, right? We see someone's teeth and we tend to have a judgment. And so to be able to get someone from a place where they feel very self-conscious, a lot of men will grow large mustaches or beards, a lot of women will cover up, they'll wear masks around town, they'll try to cover things up, they're embarrassed. And for them to now come out and smile, ear to ear, it's super rewarding, and they're volunteering more, they're involved with family, they're, like you said, they're in the workplace. It changes everything. And to be a part of that, I feel spoiled to see this process play out over and over. And again, there's different reasons. One of my favorite patients recently, she'd gone through cancer therapy, lost her teeth. And what she said is when she got her teeth back in there, is that it's like she got a piece of her life back.
Yeah.
Another go at this thing, which was a huge compliment, and it just speaks to the value of this opportunity to start fresh again. And to speak to the health impact on having these teeth, it's connected. I mean, we're all connected, right? There's the connection to our immune system, less inflammation with gum disease, our gut health when we're able to eat healthier foods.
Well, and the big one is cardiovascular health.
Oh, it's huge. Ton of benefits there. There's a ton of research directly linking that.
Right. Well, I'll just say for a lot of our patients, there's a lot of angst around that, taking that first step. And I think a lot of that, again, back to the psychology, I think a lot of that stems from, we know now that there are genetic components to, you can have two people that take care of their teeth exactly the same, and one is okay and the other ends up in dentures, right?
Yep, that's right.
Just due to the pH that someone's body runs at, like you said, gut health, other factors and impact.
Yep.
But these patients that are trying hard and they come in their whole life to the dentist every 6 months, and every time, hey, you've got another cavity, you're not brushing or flossing, oh, you've got this, you got that. It almost feels like they become like a dental failure, right? And then they just disappear from the system. After so long, they're like, you know what I'm trying isn't working, and I'm not getting the result. So it's like the dental system has failed them, and then they just disappear. They're gone for 10 years, things get worse, and then they want to come back and like address it head on, but they don't want that interaction where they come in and they get judged and scolded or whatever else they're used to. So
it's a cycle, right? They get in this cycle of like coming in, it's expensive, but nothing really gets resolved. There's no real solution, and they might get a partial, they might get some treatment on their gums, they might get this or that, and they don't last, or they won't wear them because they're uncomfortable, they don't fit well, they don't look right, and they kind of just...
It's a chasing your tail scenario that they eventually give up on, and I think we get that, and that's why for our whole team, that's always been our ethos. Is it's a zero shame situation. It's a safe space.
That's right.
We know that maybe you could have done stuff better, but there's no reason to harp on that. We just want to get somebody in, understand where they're at now, not dwell on the past, but say, okay, this is where we're at, and this is where we can go, and come up with a solution. So I think when once somebody gets into one of our offices, they feel that, and it's good to go. But that's sometimes the hardest part, right? Is them just overthinking it.
Kudos getting in the chair, because that's oftentimes, you're right, that's the hardest part, is walking in that door, getting in the chair, being a little vulnerable that first visit. Once they're there, I think the comment we always get is how comfortable people feel. Right. And generally, we'll take a 3D x-ray. That way we can give some answers right away. And we'll sit down away from the dental chair, from the sounds and smells of the dental office, in a consultation space. And in that space, we can have a direct conversation, answer questions quietly, one-on-one, which is really, really nice. I think people enjoy that interaction without feeling, like you said, judged, feeling like they don't really know answers or anything like that. But here we can say, hey, here's what we have. This is what we can go for. Is this the right fit for you? And not everyone is what do they say? If you have a hammer, everything looks like a nail.
Right.
And that's a different thing in the way we do things, is we have it set up where you can do general dentistry or the implant center at the same facility.
Right. Yeah, and I think that's really kind of more aligned on our ethical code, or our moral thing of the thing we make back as when we first start school of do no harm.
Right.
It's patient centric, is we really And I think that also plays too. We get the question all the time on the phone. Well, can't I just get a quote over the phone?
Right.
And I mean, it's hard, right? It feels a little salesy, like, no, you need to come in. But really, you need to come in because we don't know. We have people that say, I think I need a full mouth of implants. They come in and we're like, actually, you just need some
You're better than you think.
short-term ortho, some clear aligners and some bleaching, and you're good to go.
You're good to go.
And we have some people that come in, they say, I think I need an implant. And they come in and
a lot more extensive.
yeah, it's worse than we think, So I think that, and that's why we try to make that barrier so low for the consultation is, just come in, let us get that 3D x-ray, let us take a look, and then we can give you that answer of this is what you need.
Exactly.
But it's, like you said, it's patient specific. Everybody's different, and everybody's going to have different options. And then I think also part of the consult process that I enjoy is the patient. Like, where's the patient at? What do they want? And we really try to drive it off of their goals, right? Because I could, again, have the same person come in, same x-ray, same clinical condition when I do my check. And if one tells me, hey, I want to save my teeth at all costs,
right,
that could be a different direction than someone who says, I'm so tired of chasing my tail, I continually have issues, and I want something that's implant based.
And I think it's important that when you go talk to a dentist and try to figure that out, that you find someone who is listening to you.
Yeah, 100%.
I think there's the guys who, like I said, they're gonna push it. Hey, this is what we do. Come in, we'll do this one treatment. And I don't think that's right. I think everything needs to be customized to the individual and their needs. Look at their history and see how we can best guide them as a profession, as dentists. I think that's really critical that we guide in the right direction. And part of that is we put it up on the screen. We got a big screen in the office. We're able to go through and together as a consultation, but really as an advocate, like, hey, we're trying to help you out. Let's look at it together. Let's solve some problems as a team.
Well, yeah, and I think our thing is maybe we can get some street cred back for the profession, right? It's you always hear that, dentists or shysters, or they're in it for the money.
Yeah.
And it's like...
Well, I look at my own family, and my mom had an old bridge. She had a baby tooth that had gone out, and the bridge was failing, and she needs some work done. And so when people come in, I think the same as, hey, my mom's here. Like, what would I do if you're sitting in the chair, Mom? Like, what's the right thing to do? And I think and hopefully people feel that energy. And hopefully you feel that when you come in for a consultation with whoever dentist you sit across from, is that we really are just trying to do the best thing for you. And ultimately, when you're happy, everyone's happy, it works out in the end.
It's like any industry, right? Where most people out there are good, honest people trying to do the right thing.
Absolutely.
But it's those couple bad apples that kind of spoil the bunch.
Sure.
Do we want to talk about money? That's always kind of the...
Let's have that uncomfortable conversation. Frankly, I let the office manager, the implant advocate manage most of those discussions because there is more that plays into that piece as far as, do you have dental insurance? What kind of options do you have to cover the cost? But let's dive in.
Yeah, and I think this is another one where, that's probably the second most common call we get is, well, can't you tell me over the phone what this is going to cost?
Right.
And again, that's the, well, it depends answer.
Sure.
Right. So, but ballpark wise, dental implants are not inexpensive. They in fact are expensive, right?
That's right. And part of that is to get the equipment in there, you work with labs, you work with implant companies. There's a whole kind of team behind the scenes that play into getting this done right.
Well, and I think the general populace knows that, unfortunately, healthcare is just getting more and more expensive, and there's a lot of driving factors for that. But that's one area where I think that we really do shine, back to our background in the digital workflows.
Sure.
By reducing our chair time, our in-office time for each patient, it's mutually beneficial, right?
Absolutely.
If we're paying less staff, spending less time going through all those extra appointments we used to do,
right?
We've been able to lower our fees and
pass
that
those
on to the
savings
patient. But yeah, I mean, the cost for a single implant varies, and ballpark nationwide is probably somewhere between $5,000 and $8,000.
Sure, that's about right.
And then full mouth, usually, full mouth implants is usually by the arch. And I think there are a lot of nuances and important questions to ask around that. Some people will advertise a really low price, say
Yep.
as low as this, and then you dig into it and it's like, oh, well, that's actually just for the surgery, or they only do, the traditional model where they split the surgery is done by a specialist and they only restore in the office and they're only
Right.
talking about half of it. Over the years, a lot of patients have gotten caught in that where, I remember a poor patient that I saw a few years ago that came in and said, we went over everything and she said, well, I really like you, but it's actually this other guy can do it for less. And I said, oh, really? Okay, that's great. Usually we're a good value, but you do whatever you feel good about.
Of course.
Just happy to be here for whatever you need.
Right.
And she ended up going and getting it done. And then I saw her back in 4 months and just extremely upset.
Oh, of course.
And then she just had not realized that, like we talked about before, the implant has 3 parts: the actual implant fixture, the abutment, and the crown. So she had quoted, we always quote the bundle, right? Start to finish. And she had been quoted just 1/3 of the process. So, then she ended up paying, she had us finish at that point, but she ended up paying substantially more than she needed to.
Yeah, it's a shame. And you see that a lot. There's billboards, there's things you'll see online where they come across and it's kind of a hook and bait kind of thing, but it's really I don't like that. So my philosophy is like, hey, here's everything. Here's the full bundle. Here's the cost, start to finish, because that's what I would want.
Yeah.
I don't want to be tricked into a higher cost later. I think that's a good way to upset people.
Yeah. It very much feels like a bait and switch, and that's, I think, why we've tried to stay away from that. But yeah, there is a lot of cost disparity. I've seen, we see arches in our area up to $40,000 an arch. We see things advertised for as low as $15,000 an arch. But, every time I've dug into that, that's kind of a little bit of that bait and switch model.
A lot of it. Well, it depends on the final restoration too, whether it's softer printed material, if it's a nice zirconia that's smooth like enamel and it will hold up to all the things you want to eat, or if it's gonna fracture on you. So you really need, want to get something that's gonna handle an occlusal load, a chewing force on there.
Yeah, well, and again, the evolution for us, right, has really evolved to zirconia final restorations.
Oh yeah.
Just because we've, it's back to the what would you want for your own mother?
Exactly.
Right? And there's no perfect material, but zirconia is far and away, it's very biocompatible, very, very compatible with tissue long term. It's a very strong material.
Very strong.
It's aesthetic. It's pretty. It's really got, when you look at all the things that we want, it's the only disadvantage is its expense, really, when it comes down to it.
That's it. Well, the good thing is when you come in and have that conversation with us at the office or at any office, there should be some options on how to pay for this, especially if it's a full mouth restoration. And that's where that conversation should happen at that first visit, where you say, okay, here's the best here's the plan for you, here's the best treatment plan, and here's a way to get there.
Right.
And I think that's, I've heard people feel lost. We're like, okay, there's that, but I'm here. And that's where the conversation happens. Hey, here's a couple options. Here's ways people can get this taken care of without feeling like you're in a used car sales lot, which is feedback we've heard from some of the bigger corporate outfits.
Yeah. Well, and, back to the car analogy, I think a few years ago, that's what we were bumping up against, right? We had a lot of patients that could afford to get into the overdenture territory, but not necessarily to the best option. And we looked at ourselves and like, have you ever gone to a car lot and just bought a car outright? I mean, that doesn't really happen.
Not really.
Right? It's that industry's figured it out. And what we offer is kind of in that same price point.
Right.
With the difference being it's an investment in your health versus something you'll trade in a few years.
Yep.
But regardless, there should be similar options. So I think we've, for the last 5 years at least, we've really tried to make those options available where, working with financing companies, looking at alternative financing options.
Exactly.
But, again, we know this is expensive, but we can make it affordable to most people.
Exactly. And they can get it done. I've had school teachers come in, people who've been janitorial. We've had people who are retired on fixed incomes, people in all types of scenarios. It doesn't matter of their life circumstance. If they have a desire to get this done, the office, the team, we want to see that happen as well because we know the benefits. We know how it can affect someone's life, and we want to remove those barriers of cost and things like that so it can happen. And
Yeah,
so by these financing options with good interest rates, our relationships with those third parties, it makes a big difference for people.
Yeah, it does. And I think, like you said, it's the partners in the industry, right? We've worked with a lot of these guys for a long time. They know what we do is legitimate.
Right.
They know that we are being responsible on our side, so they're willing to lend kind of based on that reputation.
Exactly.
And, another thing you said that was interesting that I want to touch on a little is it really, I think, depends more on the desire of the person. I look at some of my favorite patients, or I have several patients that are waitresses.
Right.
But they just really, they value, it's the value.
They value
right?
it. Exactly.
We also have people come in that could write a check, pay for it in cash, and they don't value it. They say, I don't know, I might die soon. I want to leave money to my kids. And I think, again, that's, for us, we're not here to judge people. We're here these are your options. You have your own value system, and we're
100%.
not here to tell you what's right or wrong with that. If you want to go buy a nice truck instead, great. If you want to invest in your teeth, that's what we're here for. But yeah, we're not, like you said, we're not going to do the hard sales pitch. It's just come in, let us show you your options. We're here if you want us to help you out. That's kind of the mentality I have around it. And I think we're blessed in that we have a lot of volume. We've got busy practices, so we're really not trying to talk anybody into it that doesn't want it.
Exactly.
Ultimately, that becomes a problem for us, right?
Well, of course.
Talk somebody into it, and then it becomes our problem. Whereas I want that patient to own that decision.
Yep.
It's something they're excited about and doing, and we'll be right there along with them every step of the way to get them there. But I want them to own that decision.
I 100% agree. That first consultation is we're kind of creating a roadmap.
Yeah.
We get started and we have initial records, which when we started, 15 years ago, it was much more invasive. Big trays in the mouth, big gagging things, and now it's very simple. We used to block out 90 minutes for those visits, and now we can do them in essentially a half hour, which is
or less.
Or less, which is
our assistants are getting so good.
Oh, they're getting so good. Well, they've done it over and over and over again, and the technology's tracked. It's just a better experience all around. You and I, we're all trained and certified for IV sedation, but we elect to bring in some extra help with the CRNA, nurse anesthetist, which is helpful because it frees us up.
Well, for me, I really like that. Like you said, we used to do our own sedation, but I really liked being able to focus just on the surgery, have an experienced anesthesiology partner there to handle that aspect, keep the patient safe, and then we can focus on 100% of our bandwidth focused on the surgery.
Well, when you have a surgery that's 4 or 5 hours long, it takes the whole morning. You really, it's important to keep people healthy, keep them monitored well, but we can focus on our craft. Right, and we can really focus on getting the implants just right, the arch, the teeth in the right position, the occlusion. There's a lot of factors with the joint, the teeth, the positioning that need to be done right. There's sinuses, there's things that are managed well when we can focus on them.
Yeah.
And that frees us up to really do the best job. And when I hear about, and that'd be a question to ask when you go into a consultation, whether someone is going to have a sedation option, how that's going to be managed, if they have a third party doing the sedation for them. Frankly, if it was, again, my own mother, someone like that, I would truly want them in a controlled environment where they're going to be safe, and we know we're going to come out the other end with a good result.
Yeah, it's a serious matter, and I think that's, again, to the way we treat it is, if this was a family member, what would I do for them? And if you treat everybody that way, things work out. Things work out,
and it comes down to the surgery day. Which we do review a lot of medical history. We want to make sure, again, that we're healthy and in a good position to do the surgery. Generally, we'll do a consultation. We'll reach out to your primary physician.
Yeah, I was going to say, and I think that's a good point. We do want to do a lot of time that consult with the primary care.
Yep.
And sometimes people get a little annoyed at that. It's extra work. I don't want to have to talk to my doctor. And we try to do everything on our side to make that process smooth.
Right.
But it really, at the end of the day, I think it's helping them understand that we're trying to take care of you. We want to make sure what we're doing is safe.
Yep.
We want to make sure that you don't have some hidden medical stuff that's would lower the chances of success of the implants.
Exactly.
We want to get all that dialed in before we go into the surgery.
Well, that's a big philosophy on being DMDs versus the old DDSs. It's more a whole health focus, and I think that's the goal. Hey, we're going into the surgery. It's a pretty, invasive, serious surgery. We do it all the time. It's routine now, but we need to make sure that we are looking at other health things. So when we're finished, that you get a beautiful smile, but you're still healthy, and that everything goes smooth. Yeah. And fortunately, we've been able to never have any issues. And that's thousands of implants over years and years that have all gone smoothly. But a lot of that's because of the processes that have been set up. So I think that's important for someone to, when they're looking at it, to make sure, hey, what do you have to manage my condition? If they have diabetes, or if they have some other condition, that like a heart condition, or they're taking some medications, how does that affect the process? And to ask those questions. And we'll actually have our nurse anesthetist, we'll talk to you about it, but then we also have the nurse call you the day before to review medical history to make sure everything's on the up and up as we go into it.
Yeah, and I think that's, a lot of our patients are, because of their teeth or in relation.
Yep.
It's a chicken or egg scenario often, but not the most healthy, in the most healthy situation when they need this procedure. What we call the polypharmy, which, means just taking a lot of different prescriptions potentially,
Sure.
a lot of different conditions. And yeah, we want to manage with best practices.
Exactly. When we get to the day of surgery, it's great. We've reviewed medical history. We've previewed, the bone. We've looked at the 3D X-ray together on the screen. We have a plan. The nurse anesthetist is there. We are there as dentists. We have a whole team kind of supporting us in this process, multiple dental assistants, and a whole setup in a surgery suite dedicated to these bigger procedures, which is really nice. You come in and things flow well. There's a little more room in those operatories. And when you come in, that's when we get the process started.
Well, yeah, as you know, I do a lot of teaching.
Yes, of course.
Over the shoulder training for other dentists. And I love cooking in my own kitchen, so to speak.
Oh, for sure.
When I can be in my surgical suite and have my assistants, and the flow of it, things just, like you said, it's like an orchestra, like a concert, right? Things flow. When I go do over the shoulder training in someone else's facility, oh, where's this? Where's that? And you just don't get the same outcome.
It's just nice. It's a dance with the assistants, with the team, with the anesthesiologist. That you work in concert together. I love that, and that way things go really smooth. And frankly, the time of surgery is shorter because it goes so smooth. And frankly, when you're getting surgeries done, shorter surgeries mean better recoveries, faster recoveries, less post-op pain. And we try to stack the deck so that people have outcomes that they're really happy with.
Yeah.
So they
well, let's talk a little bit about the surgery time, because that's another question I get all the time.
Oh, all the time.
Doc, how long is this going to take? And we'll give a ballpark of 2 hours or so per arch.
Yep.
But I always tell my patient it's going to take as much time as I need to do a good job.
That's right.
Right.
Well, sure.
Every situation is different. We have some that are straightforward, and we can maybe move them a little more quickly, but always deliberately, right? I never want to be moving so fast that I don't get the best outcome.
Of course.
And I don't want to, like, on the other hand, belabor it, have, like you said, a disorganized situation where they're looking for stuff, or we're stalled out during surgery, because it's not good to have the sedation longer than needed, or have surgical site open more time than it needs to be. So I think, again, it's trying to find that perfect amount of time where we take our time to move deliberately. It's smooth as slow as fast kind of thing situation.
I love that quote. Yep. So I'm the patient. How long does it take, Doc?
It's going to take the time we need to do a good job.
All right. And which is average?
Yeah, you average about 2 hours an arch.
2 hours an arch. There you go. Great. So when we get going, we stack the deck again to get a good outcome. And what that oftentimes looks like is we have an IV in there. There's different medications that are used. Propofol is a common one that we'll use, but we'll review and make sure that's the right drug for the sedation for you. Mm-hmm. While we're under sedation, we'll generally draw some blood as well, and we'll spin it in a centrifuge. Some people are familiar with PRP or PRF, and what we'll spin it down to is platelet-rich fibrin, or PRF. And I'm a big nerd. I think this stuff is so cool. It's your own cells.
Yeah, I mean, I've been doing the PRF since 2015.
Right.
And it's one of those things that I don't know why everybody's not doing it. I mean, we're literally taking the patient's own blood, spinning it down to their white blood cells.
Yep.
And what that does is it concentrates those self-healing cells in the area. We create that membrane, place it in our surgical site. It lowers the incidence of infection almost to zero. It speeds up the healing. I mean,
Post-op pain is less.
Yeah, really the only downside
Angiogenesis.
is having the equipment and the training in office to do it.
But once you do, I mean, there's really very minimal cost to it in the surgery setup, right? Once you're set up, you have this anesthesia going. You draw some blood, you spin it down.
Yeah, well, as I say, all the expense, I think, is in the equipment, the training,
Of course.
then just the logistics of managing that as part of the surgery.
Yep. But the benefits are just fantastic.
Yeah, it's a no-brainer.
It's a no-brainer. And for wisdom teeth, but especially for full arches or even single sometimes, we'll get a membrane of PRF, we'll lay it in there. And not everyone's doing it, which is shocking. There's so much research. Well, your friends, you've done some CE teaching and things.
Yeah, I've taught with Rick Myron
Rick
quite
Myron,
a bit.
yeah,
He's
exactly.
The world expert in PRF.
He really is. He's studied in Bern, in Switzerland and kind of around the world and lectured, and the guy is phenomenal.
Yeah. Talking about nerds, he's a total nerd.
And he's got quite the hairdo. You should see this guy.
I just love the work he's done, though. He's dedicated.
He's very dedicated.
He's dedicated probably a decade of his life to this one niche, and he's improved the science.
Well, he's got the whole process down. We got exact times and RPMs for the centrifuge, the swinging buckets.
When I first taught with him, probably 5 years ago, we used to use a different
That's
brand,
right.
different system. And after being on the lecture circuit with him, I'm like, Rick, we're switching over to all your stuff. Because,
you have to.
He's gone through that.
It's all research.
It's all research based.
Yep. And it works so well. But that's one thing we do, PRF, which is phenomenal. And it really stacks the deck in a really, for healing, for the best outcome. We also will oftentimes put pain medications in the IV.
Right.
And there's also a steroid we'll use.
Yeah. And, I like to inject that steroid directly. Just because it'll stick around longer.
Exactly. So when you have a steroid on deck, pain medications, PRF, long-lasting anesthetic, when people come out of a surgery, yes, you're post-surgical. You don't remember a whole lot from that first day. But the first 2-3 days, when you stay ahead of the pain by taking your medications and stacking the deck with all these things, is generally not too bad.
Yeah, and again, another common question, right? We're talking about all the questions is, Doc, how long is it going to hurt?
Yep.
How long am I going to be? How much is it going to hurt? How long am I going to be out of? Need to take off from my job or for rest? And again, the answer, unfortunately, is it depends. But on average, I'm always flabbergasted by how minimal the post-op is compared to what you would think it would be.
Yep.
We have some patients on the one end of the spectrum that come in. They say, hey, Doc, I didn't really listen to what you said. I went back to work the next day, and I actually feel great. So we have that on one end. We do have the others that are more kind of the hyper responders that can be sore, and they do need to come in. They come in for that week post-op, and we need to prescribe more pain meds because they're still sore, and they can stretch out for a couple of weeks.
Right.
But most people are somewhere in the middle where, like you said, they're sore for a few days. They stay ahead of the pain, and then things get better. And generally, it's not like all of anything healing. It's not like a light switch switches off, but the dimmer switch where it just gets better and better.
It's better and better. I will get occasionally where the IV steroids will wear off, and that's generally around day 4. So sometimes just around day 4, people say, hey, Doc, I'm not feeling so good today, and that's when the steroid is worn off. And after that, they climb out of it, and by the time you hit a week, they're usually doing pretty darn good.
Yep.
Yeah.
Yeah, that's generally. Let's talk about some of the more common post-surgical complications we do see. Just because, I think this is educational, and
that's
we want to hit it all.
Really important.
I think a big one that can surprise patients sometimes is bruising.
Bruising is big, yeah.
And what's interesting about the bruising is it's not necessarily related to pain or to even what we do, right? To surgical technique. Again, I could have 2 patients, and I work on the one. I say, man, this was a hard surgery. We had them open longer. We had to be a little bit more invasive to get good anchorage of the implants, to get a good outcome.
Right.
I think this person's going to be, it's going to be a little rough for them healing. I'll see them back at their post-op, and they'll be, it's great, Doc, it's awesome. And then you have that one where everything goes just perfectly right.
It goes quick.
Yeah, you're in, everything works out perfectly, and you're like, oh, this person's going to be great. Then you see them back, and they've got
some bruising
under the eyes, down into the chin, and there's like, Doc, what did you do to me? And you're like,
well, generally, what's the rule of thumb? If you bruise easily, you'll probably bruise.
Yeah.
If you're not one that bruises that frequently, you probably won't bruise. It really depends on the individual.
Again, our experienced team, I often have it where I come in and I see the bruising and I'm ready for that conversation. They say, oh no, your assistant at the consult told me already that this would happen because I'm on a blood thinner.
Right.
I mean, our team knows the process so
certain
well.
Things will
that they
cause that.
often stay ahead of that. But
have you had much success with patients using arnica, like some natural remedies to prevent bruising or help with that?
Yeah, they're not everybody wants to do it, but I think the arnica does help. There's also that product Stella Life,
right?
That I've had good results with and heard good feedback from patients on that. So I think there are some natural remedy things that help. I think the big one is the ice packs.
I was going to bring that up. Yeah.
If they can use those ice packs 15 minutes on, 15 minutes off for that first day after, keep the swelling down. It seems to also limit the bruising.
And we have the head wraps we're using now. We use them constantly, and 15 on, 15 off. But that helps hold it right in the position. But that makes a big difference. Help with some of that swelling.
Yeah.
It's a thing we've heard forever. And the other common thing is just like a warm saltwater rinse, very gentle. We want to do everything gently. But when you do a warm saltwater rinse, something grandma's taught us for 100 years.
Yeah, I think it's the first few days, just leave it alone. Right?
The first couple of days, for sure. Yeah. I agree with that.
Yeah, we want those cloths to stabilize everything, but then, from there, absolutely. Not too hot, not cold water, because that doesn't feel good, but just that lukewarm saltwater rinse.
And just kind of gently turn your head left, turn it right, drool it out. But it really helps the site, the soft tissue. Things tend to do better for those who I've seen following that protocol versus not.
Yeah. Well, let's talk about the pain management too, since we're here.
Yeah, great.
What typically do we do? Every patient again is different, and it depends on their medical history, other things they're taking. But generally, what we like to do is just a basic antibiotic to help with, and typically that's amoxicillin. Again, could vary. But then I really love the pain pack protocol. Been using that for the last few years. It was developed by an oral surgeon originally, right, for the wisdom teeth. But we know that we have this opioid epidemic.
It's a real thing. And I worked at oral surgery clinic back in the early 2000s, probably 2003. It was Vicodin, like candy. And that was the protocol. That's just what you did. But like you said, it's turned into epidemic. You've had some issues, and we've seen that nationwide.
Well, and we don't want to be part of, we want our patients to have good pain control, and we want to take care of them, but we don't want to be part of the problem.
Of course not, right.
Or create addicts, or, I don't want that on my conscience.
Of course not.
So the pain pack protocol, I think, is a great kind of middle ground option where we start with Tylenol and ibuprofen together.
Correct.
Which in the pain studies for dental pain have proven to be more effective than an opioid by itself. But we use that escalating dosage, right? We start with the ibuprofen and the Tylenol. If we can stay on that consistently and have that pain managed, then we use just a plain opioid, usually oxycodone, for breakthrough pain. So most of our patients, they use non-opioid for the bulk of their pain management, and then they might take an oxycodone to help them sleep.
Well, just for those who may not be familiar, what is a Vicodin versus having it separated out? And I think that's the basic element, is a Vicodin is the opioid plus maybe the acetaminophen or Tylenol combined.
The problem with that combination, and I don't know if this is nefarious from the drug industry or if it's just, they weren't smart enough or, well versed enough in the application, but in the Vicodin you have too high of a dose of the opioid and too low of a dose of the acetaminophen. Right? So you're going to max out on the opioid, which has all the negative effects. Obviously, addiction being number one, but also nasty short-term effects, nausea, constipation, just nasty
stuff.
Being out of your mind a little bit.
Loopy.
Yeah, just the way it makes you feel. It's not the best combination.
Separate them out.
Yeah,
and you might not even need that at all. And like you said, the research study supports that you can get the management you need off of these over-the-counter ibuprofen Tylenol things. And I think it might be worth pointing out that they work in different pain systems in our body.
Yeah.
And so when you take them in tandem, they actually are more effective, right? It's an additive response versus taking just one or just the other. So when possible, and there are exceptions where people can't take one or the other, but when you can do them together in tandem, they can manage most all the dental pain after a dental procedure like a dental implant surgery.
Yeah, and I do see that too, right? With patients, if for whatever reason they're contraindicated, they've got a ulcer or whatever, and they can't do the ibuprofen, and Tylenol ibuprofen, and they have to use just an opioid. It just isn't. I mean, we get them through it, but it's just not as good of a pain management situation.
It's not. Yeah, but that works so well. This pain pack protocol, we print it out on a sheet of paper. You can track it. You can write your times. It has it all listed out for you. Oftentimes, patients I'm working with will find it works well at night to take the opioid if they need it.
Right.
Generally, when they lay down, that's when it really acts up.
Take that and it's also, they're just, that's all they focus on. You go to sleep and you don't have distraction of everything going on. And the pain, it's an experience, right? Pain is an experience. Yeah. It's not just necessarily smash my thumb with a hammer and it hurts. The same for everybody. There's the emotional aspect tied into it, anxiety around if it's going to hurt.
Yep.
There's the amount of time that they've been in pain, the location in the body. So it's this whole, it's an experience that's it's psychosomatic, right? It's the psychology and the physical all mixed together.
Yeah.
So it's a very different experience for everybody.
That's exactly right. The pain is manageable with the pain pack protocol.
Yeah.
I've seen.
Yeah, and that's, I know we kind of went deep there for a
That's
minute
okay.
on the rabbit hole, but I think it's maybe helpful for some people listening to know why we've arrived here. But yeah, when we start with the non-opioids and we add that as an escalating dose, we really do see patients come in and say, hey, it wasn't that bad, Doc.
It wasn't that bad. And a week later, they're coming out of it. Generally, when you get later into the week, another thing I'll notice are people say, I feel a tickle. Something's tickling me in here. What is that?
Yeah. Sutures.
It's a suture, a little whisker in there. But oftentimes they are dissolvable sutures. They will start to release, and you'll feel some of those tickling sensations, if you will, which is supposed to happen.
Right.
Be rest assured it's doing its job. It's supposed to release. It's generally day 5, 6, 7, around a week that we start to see some of those sutures releasing, which is normal.
Yeah, and we use a little more complex suture process, right?
Oh, sure.
I call the two-step.
The two-step.
Right, but it's a continuous running suture, which is nice because it's less little ends and less knots, more comfortable for the patient. We get better closure of the wound.
Yep.
Because we're able to use a horizontal mattress with the continuous run over the top of it.
That's right.
But I do tell my patients, it's like, if you get that little string, don't yank on it, right?
Don't
unravel my sweater.
That's right.
Up in there. So what we want to do instead is, if you have a little one that's tickling you, come in and see us. We're happy to handle it. Or take a little pair of nail scissors, just clip off that little thing and leave the rest of it alone.
Leave the rest alone.
The rest will dissolve out when it's ready.
That's right. Yeah. No, it works pretty well. And generally when I'm having the 1 week post-op, I'll take the sutures out. They've done their job at 1 week. Right. And if they're in longer...
Which is incredible, right?
Which is incredible.
Isn't it incredible how quickly the mouth heals?
We got these carotids coming up, our brain, all this important anatomy in our skull here. But we're blessed with, we're not working on our feet here, fortunately.
Good
things heal really quickly in our mouth, especially when you stack PRF and all these things along with it. They just tend to heal pretty well. Mm-hmm. We don't get scar tissue like we would in other parts of the body in the mouth, which is maybe worth mentioning. Mm-hmm. Things heal pretty well. It's very forgiving.